These are my disclosures. So what we'll be covering is the role of focal therapy, how to select patients appropriately for this, selection of modality, technical issues, and how to monitor patients after focal therapy. So why are we thinking about focal therapy? Well, screening, as we know, frequently diagnoses favorable risk disease with a very low disease burden. These are appropriate for active surveillance, but still not every patient will accept this. In the year 2000, only about 6% of appropriate patients went on active surveillance, but thanks to Dr. Klotz's efforts, this has increased. It's much more widely accepted. It was up to about 10% in 2005 and reported as high as 40% of appropriate patients accepting active surveillance in 2013. And whole gland definitive treatment may be excessive for these men, it probably is, and it also can be associated with toxicity. We have improved imaging modalities to define disease burden, which we've seen this morning, and also the natural history of prostate cancer is driven by the index lesion, which is usually the largest. It also should be considered the highest grade. Maybe the highest grade lesion is smaller. That can be a problem. So there's some definitions that we need to review. This was published last year in the World Journal of Urology. They did a Delphi consensus project. And so in defining your targeted focal therapy is lesion-based treatment. So we also know that as ultrafocal. Focal therapy can be anatomy-based zonal treatment like hemi gland or some such as that. And then focused therapy is lesion-based dose escalation, where you're still treating the whole prostate, but you're focusing more dose where you know it's needed. And then we also have to think about the ways of defining failure for focal therapy. There can be an ablation failure where you didn't destroy the lesion that you were trying to destroy, targeting failure where the treatment was misapplied and you missed it spatially, and selection failure when you chose focal therapy for someone whom it wasn't really appropriate. So that it opens up a lot more uncertainty. How are we going to define biochemically what a failure is after focal therapy, because part of the prostate hasn't been treated? We have the Astro definition, which was 3 consecutive rises, backdated to halfway between the nadir and the first rise. We have the Phoenix, commonly used definition now for external beam radiotherapy, which is nadir plus 2 with no backdating. Then the Stuttgart definition, which is quite interesting, but I don't think it's been widely applied, which is nadir plus 1.2. And they based this on an analysis of PSA kinetics for 285 patients who had been treated with focal HIFU, and the median follow-up was about 5 years. Patients were appropriate. They were all stage less than or equal to T2, with a PSA under 15, all Gleason less than or equal to 7. They had a median nadir of 0.13 quite early after treatment at 13 weeks, but they had 25% clinical failures, 24 patients had positive biopsies, 47 patients needed additional treatment, and they found the best predictor was the PSA nadir plus 1.2. So whether that will become more widely adopted, I don't know. They also looked at PSA velocity of greater than 0.3 nanograms per mil per year. So how are we going to choose a modality for focal treatment? So it should have proven efficacy in whole gland treatment. If you don't have that history of curing patients using this modality, we shouldn't be applying it focally. You need to be able to monitor the accuracy of your treatment delivery. You have to know what you've given where and how precisely. There should be a well-established dose relationship. And there are multiple options that are being suggested for focal therapy: LDR, HDR brachytherapy, which I'm going to talk about much more, cryotherapy, HIFU, photodynamic therapy, electroporation, radiofrequency ablation, laser, etc. There's a ton of stuff that they're trying to apply to focal treatment. A lot of them because they don't work too well for whole gland, but I think your perfect options here are either LDR or HDR brachytherapy. So how are we going to plan focal treatment? Well, we know that prostate cancer is multifocal in about 80% of cases. About a third may be just unilateral. Not all tumors require treatment. You could choose to ignore a clinically insignificant lesion on the opposite side of the prostate, say 3 millimeters of a Gleason 6 or something. We do know that the dominant lesion tends to drive the natural history. You can choose target volumes differently as focal or ultrafocal, hemigland or dogleg. Most series that are reported have attempted to treat all the known disease, And the required margin when you're doing this really is still up in the air. So this just shows the various planning scenarios. This is the dogleg, hemi gland, and ultrafocal. We also have to look now at some target volume definitions, and these are taken directly from our radiotherapy practice. The focal GTV is the focal gross tumor volume, and that's your clinically demonstrated disease, and that's usually obtained from a fusion of your multiparametric MRI sequences, the hypointense lesion on T2, what you see on the ADC map, and a dynamic contrast enhancement. The focal CTV, or clinical target volume, would be your gross tumor volume, which is your DIL, plus any clinically insignificant disease if you decided to treat it. So we don't use that too much. It's mainly we jump straight to the focal PTV, or planning target volume, which is the margin that you've had to add to your gross tumor to make up for the uncertainties that exist in planning and delivering treatment. So uncertainties in identification of the lesion on the images, on the registration of the images, and in your actual dose delivery. And then once we've got that PTV, or planning target volume margin, added, we restrict the boundaries because of the organs at risk. So we don't put a margin posteriorly because of the rectum. We don't let it overlap with the urethra. So Mason, I think, did some of the best work on margin definition. He had reported on 15 patients treated with a focal boost HDR treatment. He used multiparametric MRI. It was 1.5 Tesla. He used the usual sequence with no MR spectroscopy. That's kind of fallen by the wayside. Did not use an endorectal coil, but he did rigid registration of the T2 images, the ADC map, and the dynamic contrast enhancement. And he had the images contoured by 2 radiologists and repeated. So each radiologist did it twice with a time interval. So there were 4 sets of contours. And then he took the gross tumor volume as the sum of the abnormalities on T2, ADC, and DCE. And then the T2 image with that GTV information was registered intraoperatively on the ultrasound with the HDR needles in place. What they found in terms of uncertainties for contouring, left, right, ant, post, sup, int, there's a little bit of difference between them, but on average, probably about 4 millimeters. Image registration was more reproducible, basically less than a 2 millimeter uncertainty. And so they chose to add a single isotropic margin around the GTV of 4.5 millimeters, which is reasonable. So this shows the areas of interest, the GTV on the different MR sequences. It's taken from their articles, so T2, the ADC map, the dynamic contrast enhancement, and then combined here. So they do a Boolean addition to include all those areas, and that would be their focal GTV. This just shows how those areas overlap, so they don't agree completely. And then this is how it's transposed through registration onto the ultrasound. So you have your GTV with your planning target margin around it, cropped at the rectum, and this one didn't need to be cropped at the urethra because it was nicely peripheral. So how do we select patients for this? Langley published in 2012 the results of an international consensus meeting on focal LDR brachytherapy, and they determined these criteria: life expectancy over 10 years, PSA less than or equal to 15. They needed to have a multi-parametric MRI with those sequences as you see listed. Also template-guided mapping biopsy, and if all that was favorable, they needed to have unilateral disease less than or equal to half a cc with a maximum cancer length of 10 millimeters, and you could ignore clinically insignificant disease on the other side of the gland if it was less than 3 millimeters. So these are pretty strict criteria. Gleason score 6 or 7, but the 7s had to be 3+4. Stage less than or equal to T2B, and prostate size less than 60 cc's. So what are the reports on LDR focal brachytherapy? This is from Cosset. Jean-Marc Cosset in France, reported on 21 patients. The patients all had the multiparametric MRI. They didn't have template mapping biopsies, but they had a minimum of 20 biopsies. Disease was all unilateral, T1C to T2A, PSA less than 10, Gleason 3+4, fewer than 25% of the cores involved, and not greater than 50% in any core. On average, they were treating about a third of the prostate volume. They needed anywhere from 13 to 21 needles to accomplish that, with a mean of 39 seeds for the implant. And they were able to deliver mean D90, that's dose to 90% of the lesion, to their focal planning target volume of 183 gray. So they were really zapping these lesions very thoroughly. And what they found is that in these patients, when they compared them to matched patients who had whole gland treatments, the IPS score at 6 months was lower when they had focal treatments, and the recovery of sexual function was much faster. The median was at 20, and by 18, it was up to 18 by 3 months, and essentially up to 20 at a year. So they found lower urinary symptoms and faster sexual function recovery. And this is just an example of one of the lesions that was treated. You can see the seeds in place, and then the planning target volume around that got the full dose. Al-Khazai reported in 2015 on 9 patients who had multiparametric MRI and template mapping biopsies, and they did 3 plans for each patient, whole gland, hemi gland, and ultrafocal, to see which would provide better coverage and better sparing of function and adjacent organs. They used 0.5 mu strength seeds and stranded seeds, and they identified their focal GTV where the multiparametric MRI agreed with the template biopsy. So they were confirming the MR abnormalities with their template biopsies, and they added a 6 millimeter margin constrained to avoid the urethra and remain within 3 millimeters of the whole gland plan. So what you see here, that with the focal treatment, they were able to attain a higher dose to the target and lower doses to the organs at risk. You can see here, this is a urethral dose, this is the rectal dose, whole gland, hemi gland, ultrafocal, and you can see that there's a quite significant drop in these organ doses when you use the less than whole gland treatment, and the dose to the target volume also increased. So in the ultrafocal plans, you're getting 218 gray to your dose, to your target. But the important thing here is what happens if there's a random 4 millimeter shift in your seed placement. Your doses for whole gland treatment fall by 14%, in hemigland 21%, and in ultrafocal by 32%. So I think that's a caveat that with seed placement, you can achieve these things or think you are, but if there is random shift in the seed placement, if you either didn't put them exactly there, or the prostate was compressed a little bit and the seed bounced back, or it moved after you deposited it, they're not very robust plans. This shows how they identified the lesions, the typical whole gland plan, hemigland plan, and the ultrafocal plan. And for the hemigland, they did not allow seeds to be placed in the opposite side of the prostate. Laing reported just last year on 22 patients using hemigland low-dose rate brachytherapy and compared it to 120 whole gland controls. And again, they're doing all the right things. They're identifying the target with multiparametric MRI and template mapping biopsies. And this was all unilateral, low and intermediate risk prostate cancer. Same seed activity, 0.5 mu. They used a combination of peripheral strands and some MIC applied loose seeds centrally. And again, here you can see that there's a significant reduction in the urethral dose and the rectal dose when you use a hemigland treatment, the urethral dose from 175 gray down to 150, and the rectal dose from 95 gray to 75. So those can be significant in reducing toxicity, but the main sparing that they found, and this makes absolute sense, is in the neurovascular bundle, because on the ipsilateral side to the hemigland treatment, it was getting 220 gray, and in the contralateral side, only 63 gray. And that was the main sparing that they found in this treatment. And here you can see the hemigland plans, and they did allow some seeds to cross the midline in order to get full coverage of that hemigland. This is just an example from my own images, 1.5 Tesla with an endorectal coil. You can see the lesion here on T2, you can see it on the ADC map, and you can see it on diffusion contrast, dynamic contrast enhancement. So here's another example from my own practice. This patient had 2 DILs defined by T2, DCE, and the ADC maps. And so you can see how, they're in the same region, but you don't define exactly the same amount of the prostate. So all the 2 lesions are defined by the 3 different sequences. And what I tend to do is I do a Boolean addition of these. So I take a maximum volume where it can be this or this or this. So you're getting the sum of all of these. And then I do a DIL min, which is an or is an and sequence. So you're looking at only the region where all 3 coincide. And when I'm doing directed biopsies, I aim for that region where all 3 coincide. And when I'm escalating dose, I do the larger one that includes everything. This just shows how we add these up. This patient had a single DIL, so we've added them up on here and transposed it to the ultrasound. This was done with rigid registration. This shows the fusion of the multiparametric MRI to the ultrasound for fusion of the DIL. You can see that the contours coincide very, very nicely on the sagittal, on the coronal images. You do see a little bit of a spread of the on the axial images of the multiparametric MRI because of the presence of the coil. I insert the coils myself. I'm very careful about how much air I put in them because I do not want to squish the prostate and turn it into a pancake. So I usually am able to fuse these pretty readily with just a rigid overlay. But you can also use deformable registration if you wish. Deformable registration programs, there are multiple ones out there. The one we have available is through mpIM. It's contour based, so basically they're just making your MR contour fit your ultrasound contour, and it's assuming that everything within the prostate is going to deform in the same way. And we know that's not true because cancers are often very hard. That's why we can feel them. So it's not going to deform. You've got a marble and a pudding, and you can't say that the whole thing is going to deform the same way. So I think there's more uncertainties using deformable registration than there is actually using a rigid overlay if you can make your prostates look the same. This is an example of a focal salvage case. So you can see the lesion on T2 here. You can see it with the contrast enhancement, and you see the black hole on the ADC map. This is a challenging one because it circles right around the urethra. This guy had 74 gray 10 years ago. PSA was rising, doubling time 12 months, staging negative, and his biopsies had shown recurrent Gleason pattern 4. He definitely did not want hormones. He wanted salvage treatment. So I did him with LDR focal brachytherapy. He had a small gland, so we ended up treating like 2/3 of the prostate, but there's still if you look at the urethral dose here, it's going to be between 125 and 100%. So there is central sparing here with a focal approach. So in summary, for focal LDR brachytherapy, LDR is well suited to focal treatment. There's an established radiobiologic basis, known tumoricidal activity in whole gland treatments. The post-implant dosimetry evaluates the actual delivered dose, and our parameters are well defined. Other focal approaches based on tissue ablation are less able to predict efficacy and toxicity by quantitative means, but the caution here is you shouldn't try to be too focal because it's not robust for seed misplacement or movement if you're only putting in an average of 25 or 40 seeds. So that you have to be very cognizant of that and careful. So let's move on to HDR focal therapy. There are several advantages over LDR, potential advantages. With the LDR implants, you can get seed loss, migration, misplacement, even with strands. Ultrafocal plans are very sensitive to seed misplacement or displacement. Operator performance is obviously a huge factor. And the quality is evaluated after the fact, and it's difficult to correct. You could add more seeds, but you can't take them out. Some of the inherent advantages of high dose rate is that the dose is optimized by manipulation of dwell times and dwell positions of a stepping source, and this can correct for slight deviations in your needle placement. The critical organ doses to the rectum and the urethra can be very tightly controlled. As Dr. McLaughlin was showing, we've changed the configuration of the prostate. When we bring the probe down, we stretch that rectal urethralis. Well, you treat with the probe in, so it's going to stay in exactly that same position, and you know exactly what dose you're giving to the rectum because it is not moving. You have the potential to push extra prostatic dose where you need it if you do, and what you plan is exactly what you get. HDR treatment planning has varied over the last years. The procedure is always ultrasound guided under anesthesia, but the majority of earlier published results were from CT-based planning, which meant after you had the needles in and held there with a template, you suture the template, you wake the patient up, you move them to the CT, and then back for their treatment. So there's a lot of shifting the patient around, which loses all your precision of your needle placement. Now that we have ultrasound-based planning with programs from both Elekta Nucleotron and Varian, you can do it all in one step. So you never wake the patient up, you never move them off the table. So you insert the needles, plan the treatment, deliver the treatment all in one session. But this does require that your procedure suite be shielded for treatment, or that you've got a treatment bunker that you've converted to anesthesia. So that's a little bit of an organizational barrier for some centers. This just shows inserting the needles, advancing them on sagittal ultrasound to the base of the prostate, then reconstructing the path of each of the treatment catheters on your sagittal images and identifying them for your dose calculations. This is a reconstruction of the prostate with the needles in place and then the transfer tubes connected and ready to treat. And the entire procedure, treatment door to door, is about 2 hours or just a little under. This was obviously a whole gland plan, but again, you can see the urethral sparing, and you can easily imagine how treatment can be focused to exactly where you want it. There are a few reports on focal HDR. Banerjee published in 2015 on plans comparing whole gland, hemi-gland, 1/3 and 1/6 volumes, and divided the prostate into right and left halves at the urethra, and then divided each half into base, mid-gland, and apical thirds. And you can see here the white is the urethral dose, the blue is the rectal dose, and as you go from whole gland to hemi-gland to 1/3 to 1/6, they get less and less. And you can see here the rectal 1 cc dose is 70% of prescription for whole gland, 61% for hemi-gland, and when you get down to 1/6 of the gland, it's down to 39%, and a similar sort of decline for your urethral dose. So it's much easier to spare these organs very significantly with focal planning. Mason published on focal HDR, again comparing whole gland, hemi-gland, and ultrafocal plans for a single 19 gray. He used a 6 millimeter margin for the ultrafocal plans and 3 millimeters for whole gland. And again, target was defined correctly, multiparametric MRI and template mapping biopsies. He found for the focal plans you had to make your treatment catheters a bit closer together. Usually they're separated by 1 centimeter, so he brought them down to 0.75 centimeters. The organ at risk constraints were pretty typical. The average size of his focal gross tumor volume was 0.6 cc's, but by the time you add your margin, it's up to 4.4 cc's. And one of the talks this morning was saying they were adding 9 millimeters. That would make a huge planning target volume. And you can see here the doses to the focal planning target volume. The D90s for whole gland, it was 21 gray, hemi-gland the same. For ultrafocal, it was a little bit higher. And the organ at risk dose, the rectal dose, and the urethral doses were markedly reduced in the ultrafocal plans. So he did a similar calculation here as to what was done for the LDR focal plans, where the dose was falling by 30% if you had a 4 millimeter random shift of the seeds. He said if you use CT-based planning, where you're having to transfer the patient from the procedure table where you've inserted the catheters over to a CT couch for your CT for planning, and then back to a treatment table, you have to assume a caudal shift of those catheters by an average of 4 millimeters. Quite often it's a lot more than that. And if you're doing a focal treatment, your dose to your PTV will fall by 21%. Whereas with ultrasound-based planning, where you're not moving the patient at all, the mean uncertainty is less than a millimeter, and your dose is maintained to within 2%. So what you can actually deliver exactly what you plan. These are some illustrations from that paper showing their GTV, typical whole gland, hemi gland, and there's their focal target volume. Hosnay published, actually just this year, a really interesting exercise that they did on MR-guided focal HDR brachytherapy. So the target, again, is defined in mpMRI, deformably registered onto a post-catheter insertion MR. In their OR suite, they have an MR on rails, so they can incorporate this into their workflow for the actual implant. The PTV was defined as a 5 millimeter margin on the gross tumor volume, except cranial caudal, where they thought there was more uncertainty, so they added 9 millimeters. And what they aimed to do, they were going to treat these lesions focally with either 2 fractions of 16.5 gray in 2 separate implants, or a single fraction of 24 gray if everything was favorable. So for 20 patients, 7 of the plans were able to be converted to a single dose 24 gray, and they didn't need to give a second treatment without exceeding the organ at risk constraints, but the others they had to proceed with the 2 doses. The constraints were pretty usual. They were using about 11 treatment catheters. Well, they inserted 11, but they ended up only using 4. The GTV volumes were, again, what we're seeing. We've seen 0.6. This was 0.7, with a planning target volume of about 5.5 cc's. And this is interesting. It shows a typical 1 fraction plan. It was a nice little peripheral lesion, and they were able to safely give 24 gray, and that completed treatment. This was a bigger lesion, more rectal dose implicated, closer to the urethra, so they couldn't safely do it in a single fraction. They stopped at the 17 gray and did a second implant, or 16 gray. And this one they couldn't treat at all because of the location of the lesion. They just could not meet the organ at risk constraints. My protocol for focal HDR is multiparametric MRI to identify the DIL, Boolean addition of the DILs as I described, contour the prostate, the urethra, and the DIL, do a pre-op truss with aerated gel in the urethra, fuse the multiparametric MRI, which is done at our adjacent hospital, to the ultrasound for transposition of the DIL. You can use rigid registration, works most of the time, or deformable if you need to. For the HDR procedure, we fuse the intraoperative truss with the catheters to the pre-op truss with the DIL, which is just a simple overlay because it's the same imaging, same organ, and they just match perfectly. Then do your dose optimization and treatment delivery. So the summary for HDR focal brachy, there's many advantages over other modalities. The dose is precisely controlled and delivered. There's no seed loss. There's no organ motion. There's no patient motion. The dose is easily sculpted to the target with avoidance of critical structures, and it has proven efficacy. So it can be whole gland with a focused boost, which is what we do for high-risk disease, focal only, monotherapy, or it can be combined with external beam. Defining success, as I indicated at the beginning, can be difficult because there's no validated PSA outcome. So you really have to, for focally treated patients, have active monitoring similar to that for active surveillance. There can be significant undetected disease, which you didn't treat. There can be residual disease in the treated area, and there can be cancer progression. So biopsy of treated and the untreated areas, I think, is mandatory. And the follow-up can't rely on PSA because we've got so much untreated prostate. And hopefully multiparametric MRI will play a larger role in following these patients, but that requires further validation. Recommendations for focal therapy: clinically significant disease in one area of the prostate. You can monitor the insignificant stuff. Accurate localization. You can't just have something from your ultrasound-guided, sextant biopsies. So multiparametric MRI and template mapping. Follow-up and monitoring as similar to the active surveillance protocols, including biopsy. The optimal technology for focal therapy, I think, remains to be determined, but I think I've shown that both LDR and HDR are very appropriate and well suited to it. The planning issues such as margin determination are still out there, but 5 to 6 millimeters seems logical. It's what's being adopted. And the level of evidence is still very low concerning disease control and survival. Thank you.